Hello, everyone, and welcome to the Coloplast sponsored session, Modern Management of Complex Woundscapes. I will be the moderator today for this session. My name is Kim Ferner. I'm a territory manager for Alberta, as well as a field sales trainer for Western Canada. So before we begin, just a few housekeeping notes. During the presentation, please don't hesitate to input any questions into the Zoom Q&A box. I will be collating these questions and posing as many of them as I can at the end of the session. So on behalf of Coloplast, I have the privilege today of introducing our guest speaker, Melody Yaceyko. Melody is a community-based NSWOC who has practiced in the Edmonton zone with Alberta Health Services for the past 17 years. In 2018, she completed her postgraduate degree and is now also a family all-ages nurse practitioner. Melody is a clinical consultant who empowers clients, families, and health professionals by providing evidence-informed wound, ostomy, and continence education, as well as practice strategies. She also routinely lends her expertise and clinical leadership to program, zone, and provincial working groups, committees, and of course, advisory boards. So without further delay, I'm going to hand it over to you, Melody.
Hi everyone, I'm Melody. Thank you so much for taking the time to join me today for this discussion about Biatain AG foam, an ideal dressing strategy for modern management of complex woundscapes. I am a community-based nurse specialized in wound, ostomy, and continence with Alberta Health Services in Edmonton zone. I've been a practicing clinical consultant with home care for about the last 17 years or so. I've been contracted to create this presentation. I researched it and developed it myself with professional support from Coloplast. Photos and case study data taken from clinical practice have been used with consent. I'll receive an honorarium for my efforts. And last, I acknowledge that clinical results may vary. Please review and consider manufacturer's guidelines before initiating any product or therapy. To begin this presentation, I'll briefly touch on the importance of client-centered dressing selection. Our focus, however, will be geared towards comparing and contrasting Biatain AG foam dressings with dressing properties that are considered ideal. Throughout this discussion, I hope to familiarize you all with Biatain AG's advanced form and function, including this portfolio's uniquely engineered structure, proprietary 3D fit technology, and innovative antimicrobial silver complex. We'll touch on how these advanced dressing features optimize conditions for wound healing and support cost-effective care, and we'll look at clinical efficacy using case studies taken from professional practice. Following this discussion and a brief summary, I look forward to answering any questions you may have. In general, in our community of professional wound practice, we accept that there is no magic bullet for wound care. Wound dressings and therapy selection should always be driven by factors that are specific to each individual and supported by evidence and professional knowledge. Considerations driving client-centered dressing selection are well presented in Wound Canada's best practice recommendation for the prevention and management of wounds. These are summarized on this slide. As stewards of increasingly limited healthcare resources, however, it's also imperative that we understand how to select products and therapies that efficiently yield the best possible clinical results. In short, I presume we are all interested in learning how we can get more bang from our wound product bucks. In preparing this presentation, I spent some time reviewing articles that identified ideal dressing properties. I then selected the most overlapping or commonly cited of these to compare and contrast with Coloplast's innovative line of antimicrobial foam dressings, Biatain AG. So, in spite of my lingering cold, it is my pleasure to discuss the Biatain AG portfolio of products with you today. I've had good success with this line in my own practice, but let's see how it stacks up against the ideal dressing properties I extracted from the literature. Please note, these properties are neither inclusive nor being discussed in any particular order. Thermally insulate the wound and protect from trauma. Evidence has shown that neutrophil, fibroblast, and epithelial cell activity decrease when the temperature of a wound falls below 33 degrees Celsius, or when it gets too cold, essentially. Insulating most wounds to a baseline core temperature of 33 degrees increases blood flow improves oxygen tension, collagen deposition, and immune function to support faster wound healing with fewer complications. Studies on pressure ulcer management showed fastest contraction when wounds were kept just slightly warmer, between 36 and 38 degrees. Delayed wound healing, however, is seen when wounds are heated to temperatures above 42 degrees Celsius, or when they're kept too warm. Like many foams, Biatain AG is comprised of a polyurethane substrate. In general, polyurethane is a biocompatible, mechanically stable, non-toxic, hypoallergenic, non-shedding, and flexible material. Open-celled polyurethane foam dressings have also been criticized, however, for being poor thermoconductors, meaning when the dressings are dry, air trapped in the pores holds heat and potentially increases the risk for hyperthermia, or very high temperatures, at the level of the skin and wound. This can exert potentially negative effects on skin and wound microclimate, depending on the type of polyurethane foam product selected. Fortunately, the Biatain portfolio of products incorporate a uniquely engineered structure to support form and function, unlike any other polyurethane foam dressing. Absorb exudate. The polyurethane substrate in the Biatain portfolio is designed with an alveolar pore structure that promotes vertical absorption of drainage into the dressing. Liquid is a better thermoconductor than air. In theory, drawing exudate vertically into the open-celled alveolar strands may promote superior thermoregulation as heat is transferred through the dressing via moisture uptake, wicking, and gaseous transfer. As exudate is absorbed, this uniquely engineered cellular structure also helps retain the drainage in the pores of the foam to minimize flashback and maceration, even under pressure. Support moist wound healing and gaseous transmission. When skin is injured, evaporative moisture loss from the wound surface is about 20 times greater than that of intact skin. Unless covered with dressings to support moisture balance at the surface, many wounds will dry out and healing will be delayed. Supporting and maintaining a moist wound environment has been shown to expedite healing by improving cellular motility and the formation of new blood vessels, reducing cellular dehydration and death, enhancing autolytic debridement, and reducing pain. In addition to good absorptive qualities, facilitating optimal moisture levels at the wound surface also typically requires a dressing to incorporate a mechanism for moisture to escape the dressing. The outermost layer of the entire Biatain line of foam dressings is engineered to support moisture vapor transfer. The film backing is waterproof and impermeable to environmental contaminants and opportunistic pathogens. It has been demonstrated that bacteria can pass through up to 64 layers of moist gauze. Wounds covered with occlusive dressings, including the entire Biatain portfolio of products, have been shown to have lower rates of infection than those covered with conventional gauze. Let's take a moment to review. Biatain AG uses a polyurethane substrate to efficiently protect and insulate wounds. These foam dressings are uniquely engineered to incorporate an alveolar structure that absorbs moisture vertically into the foam and disperses moisture vapor through the outermost occlusive film layer. In head-to-head comparisons of competing foam dressings measuring absorption, total fluid handling capacity, and gas permeability measured as moisture vapor transfer, Biatain foam yields some pretty compelling results. Be conformable. Further to this line's structural innovation, Biatain foams, including Biatain AG, also incorporate proprietary 3D fit technology to support an optimal moisture balance at the surface of the wound. Many foam dressings, unfortunately, will demonstrate cupping when moistened, but filler dressings are also typically required to fill the remaining dead space or gaps in the wound. This usually increases the cost and complexity of most dressing protocols substantially, but failure to fill the wound adequately increases risk for drainage pooling and subsequent infection, maceration, and tissue degradation or erosion. Foams with 3D fit technology maximize intimate contact with the wound bed by conforming to the exact shape and contour, intimately, to a maximum depth of 2 centimeters. This minimizes gapping and pooling in dead spaces. The clinical relevance of this feature is most simply understood by comparing the irregular surface of a wound or woundscape to mountainous terrain. Peak projections in the wound topography will suspend standard foam dressings between high points. Even dressings designed to integrate convex swelling or cupping as exudate is absorbed will simply hammock. The interface ends up suspended by tissue projections that prevent direct contact between the dressing and the deeper, irregular surface areas. In exudative wounds, failure to maintain intimate contact between the dressing and the wound surface allows drainage to pool in gaps and dead spaces. This, of course, impedes optimal moisture balance and ultimately increases the risk for infection, maceration, and tissue breakdown. Support non-adherent atraumatic removal and reduce or eliminate pain. Pain associated with dressings is also most commonly associated with suboptimal moisture balance and tissue adherence or skin stripping associated with adhesives. We reviewed how Biatain AG's 3D fit, form, and function supports a moist wound environment, an essential part of atraumatic care. And yet we understand that dressing removal is also consistently reported as one of the most painful components of wound care. Why? Simply, the bonds that form between adhesives and the skin play a major role in skin stripping, especially at the edge of dressings, and contribute to cutaneous trauma and pain. Biatain Silicone AG incorporates atraumatic silicone technology across the foam interface and border to significantly reduce the risks of painful dressing adhesion and skin stripping. In my practice, silicone is absolutely the adhesive or interface of choice for high-risk skin in infants and very elderly clients. Now, if I'm being completely honest, this slide breaks my heart a little because it's a screenshot taken from a really wonderful short video clip that really captures Biatain AG silicone's properties in action. In the clip, the clinician is peeling it off and we can see how easily it's removed from the skin, and yet we see this remarkable 3D fit technology and how it contours intimately to the irregular woundscape that we see on the screen. Unfortunately, when it comes to technology, I'm more of a muggle than a wizard, and I could not make it play, so screenshot it is. Regardless, you can see this remarkable contouring where the 3D fit technology meets this irregular woundscape. Biatain AG is also available in adhesive and standard non-adhesive forms. Biatain AG adhesive incorporates Coloplast's proprietary 3D fit technology and polyurethane foam substrate with a thin hydrocolloid border. This adhesive option facilitates an improved seal compared to standard acrylates. Moisture absorption into the vapor-permeable hydrocolloid promotes superior extended seal flexibility and contamination prevention. This versatile option is also great for clients with complex peri-wound anatomy. It adheres to dips, pleats, and skin creases and resists rolling and lifting really quite well. Biatain AG is also available in a standard non-adhesive version that can be applied using any adhesive tape or alternatives such as cling or mesh of any type. Last but not least, I'd be remiss, of course, if I didn't also mention that increased pain, the topic of this slide, is often one of the first indicators of local wound infection. Applying an advanced antimicrobial dressing is one of the simplest ways to quickly reduce or eliminate responsible pathogens, optimize healing, and restore client comfort. It's pretty clear few dressings are engineered with this many features. Biatain AG foam maximizes fluid handling capacity by utilizing an open-celled alveolar structure for vertical exudate absorption and superior retention. The 3D fit technology eliminates the gaps and supports intimate contact with even the most irregular of woundscapes for optimal moist wound healing in wounds up to 2 centimeters deep without requiring any additional filler products. The outermost film layer protects the wound from contaminants while facilitating exceptional moisture vapor transfer. Biatain AG also incorporates broad-spectrum soluble silver for management of local wound infection. This is exactly the type of ulcer I might use Biatain AG on, or basically any exudative wound showing early signs of local infection. So let's talk a little more about the infection continuum and when topical antimicrobial dressings are indicated. Coloplast complies with and endorses current evidence regarding the use of antimicrobial silver dressings in clinical practice. The International Wound Infection Institute's Wound Infection Continuum, shown here, is included for reference in the Biatain AG portfolio monograph. Note, antimicrobial silver dressings are not indicated in contaminated or colonized wounds. The tipping point for treatment is identified when the microbes in a wound elicit a host response, typically presenting as signs and symptoms of local infection, and this was formerly referred to as critical colonization. Most commonly, locally infected wounds demonstrate increased erythema, edema, warmth, or pain, purulent exudate or increased volume of wound drainage, and new or worsened malodor. Systemic signs, such as fever, chills, and leukocytosis, are indicators of spreading infection which, if left untreated, may progress to bacteremia or septicemia. In such cases, systemic antibiotics are warranted. Infected wounds should be cultured with sensitivities used to tailor antibiotic choice. Once again, this is the sweet spot for treating with a topical antimicrobial. Consider that signs and symptoms of local infection may be obvious or disarmingly inapparent. This drives home the importance of continuously reassessing the client and the wound. The mantra I use in my practice is cause, support, treat, repeat. Cause. Have I correctly reduced or eliminated the primary cause of this wound and any possible alternate contributors to non-healing? Support. This key element of care requires continuous assessment and review of client-specific factors, including their health and surgical history, environment, culture, lifestyle, behavior, knowledge and beliefs, nutrition, or socioeconomic status. Identifying the variables that have the potential to confound healing in each individual's case and customizing their care expedites and improves overall outcomes. Treat. Treatment should always reflect understanding of etiology, client-specific considerations, evidence-informed practice, and probably most importantly, the goals of care. Repeat. Repeat is usually just a reminder for clinicians to focus on the prefix re, continuously reviewing, reevaluating, revisiting, and reassessing the person, their experience, and their response to treatment helps drive efficient client-centered wound care. In my experience, systematic wound assessments and timely intervention, including the application of antimicrobial dressings when signs and symptoms of infection are assessed or suspected, is essential. Not surprisingly then, another ideal dressing should protect from infection and remove or contain odor. Wound malodor is detrimental to quality of life, often eliciting psychological stress, distress, shame, or embarrassment, and causes increased risk for social isolation. The most common causes of wound odor are infection, especially when anaerobes are present, and tissue necrosis. Bacterially produced malodorous molecules encompass a range of volatile metabolites, including cadaverine, putrescine, sulfur, and short-chain fatty acids. Trust me, they all smell as good as they sound. The broad-spectrum silver found in Biatain AG can be used to manage wound odor resulting from local infection. In addition to vigilant wound cleansing and debridement, absorbing and controlling foul-smelling exudate is essential. Biatain AG's excellent moisture management capacity, occlusive backing, and antimicrobial silver-impregnated 3D fit foam help to contain odor while eliminating the causative pathogens. As I mentioned, soluble ionic silver is a potent, broad-spectrum antimicrobial agent. In its metallic or elemental form, it's unreactive and can't kill bacteria. To become bactericidal, a silver atom must lose an electron and become a positively charged ion. Moisture facilitates the process. The dressings essentially need to be wet in order to release their antimicrobial potential. Silver ions are highly reactive and attack multiple sites on and in bacteria when moistened. They bind to and disrupt bacterial cell walls, causing extravasation of cellular contents. Silver ions transported inside bacteria will also disrupt metabolic and reproductive processes by binding to proteins and interfering with energy production, enzyme function, and cellular replication. When used with empiric wound bed preparation strategies, antimicrobial silver dressings can both treat local wound infection or help prevent infection in very high-risk clients, such as those with peripheral vascular disease, diabetes, immune suppression, complex comorbid conditions, and more. Biatain AG specifically uses a novel ion exchange system to achieve sustained delivery of high volumes of soluble ionic silver to the wound bed. The silver in these dressings is reversibly bound to zirconium phosphate molecules that are impregnated in a polyurethane foam substrate. As exudate is absorbed into the phone, the cations in the drainage trigger the continuous release of large volumes of silver for up to 7 days. The use of high-volume sustained-release silver in these dressings has been shown to effectively kill wound pathogens and reduce the incidence of recolonization in a wound bed over time. By incorporating an occlusive backing that's impermeable to bacteria and the sustained release of large volumes of soluble ionic silver, Biatain AG can prevent or treat local infection while containing and reducing wound odor. As discussed, the innovation of 3D fit technology eliminates gapping and drainage pooling between the wound and the dressing for optimal contact between the dressing and the wound. Biatain AG foam dressings can be used to prevent adverse wound-related events in very high-risk clients, treat local infection, reduce biofilm, and prevent biofilm reformation. A biofilm is an assemblage of microbes that are enclosed in a self-secreted extracellular polymeric substance, or EPS, made primarily of polysaccharides. They can be homogeneous or heterogeneous, planktonic, which basically means free-floating, or sessile, which means fixed, and form on any number of surfaces, including wounds. Biofilm formation in wounds is most problematic when the microbes within it are pathogenic. The EPS is insular, you see. It protects the microbes from the host's own immune response, including systemic antibiotics, as well as from external assault, from a lot of antimicrobial dressings, for example. This often results in delayed wound healing, deterioration, and/or recalcitrant infection. We understand that a number of factors relating to moisture, volume, and quality, as well as surface characteristics, contribute to biofilm formation. Specific to wound management, the risk for biofilm development generally increases in the presence of excess pooling of drainage, rough, irregular, or complex woundscape, and chronicity. Chronic wound environments are typically much more alkaline than acute wounds and are certainly much more prone to biofilm formation. Coloplast has demonstrated that using sustained delivery of high doses of broad-spectrum antimicrobial silver is an effective way to eradicate a mature biofilm in a wound. Since I love a good analogy, think of the pathogens in a biofilm as the musicians in a rock band, synergistically working the stage or wound to make their microbial music. If a small number of excited fans, for the sake of this example, soluble antimicrobial silver ions, try to rush the stage and attack the band or microbes a few at a time, they're easily stopped by the biofilm security. In this case, the insulating protective extrapolymeric substance. However, if a very large volume of fans, or silver ions, relentlessly charge the stage over a sustained period of time, the insulating security of the EPS is overwhelmed and the mature biofilm, I'm thinking 90s metal hairband, doesn't stand a chance. The continuous delivery of large volumes of soluble ionic silver will strip the biofilm pathogens of their mullets, mesh crop tops, and leopard print spandex in no time. But I digress. This is an approach that I have not seen used in other antimicrobial dressings. Theoretically, antimicrobial silver dressings that utilize nanoparticulate technology to release exceptionally high doses of silver into a wound very quickly may not be able to effectively penetrate biofilms or prevent reformation over time due to the rapid depletion of silver ions in the dressing all at once. Conversely, products that use lower concentrations of sustained release silver rely on added ingredients such as surfactants or metal chelators to reduce or eliminate biofilms. So when I was researching this line of products, I was quite interested to know, and actually I'm grateful to the clinicians at Coloplast for helping me understand the science behind their technology. Figure A illustrates the rate of release of silver from Biatain Silicone AG and Biatain AG non-adhesive, measured at 4-hour intervals for 7 days. Note that while some competitors showed higher initial release of soluble silver, Biatain AG products release a higher concentration over a longer period of time, which again may reduce the risk for subsequent wound recolonization or biofilm formation. Figure B shows the amount of silver released over 7 days. Note both Biatain Silicone AG and Biatain AG non-adhesive released greater than 450 parts per million over a week. Proactively managing biofilm in a wound and treating infection locally reduces downstream costs associated with spreading infection or sepsis. It's one of the most strategic, cost-effective ways to utilize healthcare resources in an invaluable way to protect clients and families. Demonstrate cost effectiveness. Combination dressings in general with adhesive skin contact layers lower overall treatment costs by reducing the time required for dressing changes. This reduces the amount of professional time required and the associated cost of care. Although most occlusive dressings do have a higher per unit cost than conventional gauze, this lower price tag, of course, does not always reflect the increased wound closure rates that are seen with advanced products or reduced frequency of dressing changes required, and again, the reduced need for professional nursing time that are realized. I encourage you to review your formulary of contracted pricing agreements. A quick review of ours showed that using Biatain AG foam for management of local wound infection may cost up to 4 times less per dressing change than using an alternate silicone bordered foam with a secondary antimicrobial filler. The dressing should be easy to apply and remove and require infrequent changes. Throughout this pandemic in home care, we've relied maybe more than ever on clients and families to perform wound care independently. The Biatain product portfolio is easy to use, and the no-touch backing system makes the dressings easy for even laypersons to apply safely. Reducing the frequency of dressing changes is good for the wound's bottom line. Changing dressings less frequently reduces the risk for contamination and dressing-associated pain and helps keep the wound well insulated. Similarly, a typical dressing change reduces temperature, as I mentioned, by about 3 degrees Celsius. Using advanced wound care products to facilitate prolonged wear times helps maintain thermal regulation and limits wound healing time lost to temperature recovery. The Biatain portfolio certainly ticks a number of ideal dressing indicator boxes, including cost savings. But let's look at one of the most important considerations more closely: clinical effect. So this group of case studies uses clients not just from my own practice, but some that were in the care of my colleagues. I always find it very interesting to look at how others find the products and the clients that they select them for. I learn a lot from that in my own practice. So this first client is a very lovely lady of my own. She was widowed following the death of her husband of 65 years. She has loving, attentive children, grandchildren, and great-grandchildren. This lady was in care with our programs for several years because of her complex comorbid picture and ongoing home care needs. On 2 occasions, she had previously developed spontaneous abdominal wounds in different locations. She had a very complex surgical history. Interestingly, on both occasions, after about 3 months of moist wound healing, fully knotted sutures emerged from her wounds, and then they spontaneously closed. When her most recent wounds occurred, again spontaneously, she was screened for infection and sent for ultrasound directly over the new wound that formed. She was determined to be positive for low-density colonizers, but no surgical materials were detected on imaging. Unfortunately, her wounds persisted for months. Numerous dressings and treatments were trialed, including hydrofiber with and without silver, nanocrystalline silver, hydrocolloids, ORC collagenase with and without silver, silicone interfaces, calcium alginate with and without silver. The image on the left of the slide shows the wounds before Biatain silicone AG was tried. Silver hydrofiber had been used up until that point. The slide in the middle of the frame shows the wounds 3 days after the Biatain silicone AG was applied. And the slide to the left shows the wound after Biatain silicone AG had been in use for 2 consecutive weeks. The charted nursing narrative relayed that the client called this dressing a miracle and reported that the Biatain silicone AG foam was the only product that alleviated the burning sensation or pain that she had to these wounds. In the same narrative note, her nurse inquired about how to access this product through our formulary. Fortunately, I didn't have more samples to give her at that time, but I did have some Biatain AG non-adhesive. The image on the left shows when the AG non-adhesive was applied. 4 days later, when her dressing was removed, stool was observed to have seeped under her dressing, and she appeared to be presenting with signs and symptoms of local infection. Her physician presumptively prescribed antibiotics. A wound specimen was subsequently collected, and although I expected enteric bacteria, her culture was positive for moderate density 3+ Staph aureus. The photo on the right shows her wound, again, 3 days after starting antibiotics and 1 week after Biatain AG non-adherent was in use. At this point, however, her nursing team decided to discontinue the non-adherent AG foam, and they wanted to wait for more silicone AG samples to arrive because these were preferred by the client, and the nurses felt that her fragile skin was much better suited to the silicone interface and adhesive. So I did secure a few more samples for her. The photo on the left of the screen shows her wounds before the Biatain silicone AG was applied for the second time, and the photo on the right shows her wounds response after 1 week of continuous Biatain AG silicone use. Pretty remarkable. This client was a wheelchair-bound gentleman being followed by one of my NSWOC colleagues, Gretchen Delacruz. He had a chronic injury resulting from the combined problems of pressure, friction, shear, and moisture. Prior to initiating Biatain silicone AG, this gentleman's nursing team had been painting this chronic wound with betadine to reduce opportunistic infection. My colleague Gretchen, however, felt the wound might be healable with a moist antimicrobial protocol, and this was consistent with the client's expressed goal, and so she decided to try the Biatain silicone AG. The photo on the left shows the wound on the day the product was first applied. Moving across the frame from left to right, we see the effects of progressive moist wound healing. These effects, of course, are most fully realized after 7 weeks of treatment. It's readily appreciated that the Biatain silicone supported autolytic debridement without impairing the integrity of the surrounding tissue. Specifically, it didn't mess up the microclimate. Admittedly, this process may have been expedited by performing early conservative sharp debridement, a skill that all of the NSWOCs on my team are experienced with and qualified to perform. However, there are a number of client-centered environmental or workload issues that might have confounded this that I'm not aware of. I also acknowledge that not every clinician can debride or has access to this service, so instead I thought it would be nice to include this case study to show that Biatain dressings may be a more accessible option for supporting autolytic debridement and moist wound healing in virtually any practice environment. This next client is a gentleman in the care of another of my NSWOC colleagues, Nancy Moody. He's an older fellow with an unfortunate myeloproliferative disorder, polycythemia rubra. Leg ulcers are common in this disease, but according to the literature, it's not entirely clear whether it's the disease itself or the treatment that is required that is most contributory. So we see on the left of the slide, in July 2020, the client was received to home care for surgical wound management, including this low leg donor site. October, we see 3 months later. January, 6 months after admission. So very clearly this was a chronic wound. The care plan shows that dressings, therapies used over a 6-month period included silver hydrofiber, nanocrystalline silver, gentian violet, methylene blue impregnated foam, iodoform, low adherent interfaces including petrolatums, hydrocolloids, AMD gauze, superabsorbent liners, and negative pressure therapy. So my colleague basically threw the book at this gentleman. Here we see in April, so a full 9 months after he came to our program, she initiated Biatain AG adhesive. And so again, 9 months of moist wound care with our program. On April 29th, we see improvement after 2 weeks of Biatain AG adhesive being used continuously. And then we see on May 13th, after 4 consecutive weeks of Biatain AG adhesive. Now these might be considered incrementally small improvements or a slight contraction, but given what this gentleman's been through, I think it's pretty remarkable. Like me, my colleague actually ran out of samples. So after approximately 7 weeks of Biatain AG adhesive, and the consultant's notes indicate the wound exited was scant, they changed the protocol to Prontosan soaks with an alternate bordered foam. The foam used here was Mepilex border. And then we don't see much progression after that. It kind of stayed recalcitrant after 4 continuous months of Mepilex border. The most current images of this chronic wound suggest it's certainly stable, but the contraction that was noted during the Biatain AG adhesive trial had all but stalled. When we talked about this as a team during our case study, Nancy said, "Good grief, just need something like that, some kind of to wiggle across your forehead," and she's actually planning on restarting the Biatain silicone AG for this gent. So, to review, Biatain AG foam dressings use a polyurethane substrate to protect and insulate wounds. They're uniquely engineered with 3D fit technology to minimize interface gaps and optimize intimate contact with even the most irregular woundscapes up to 2 centimeters deep, eliminating, of course, the need for additional filler products. The proprietary alveolar cellular structure absorbs and traps exudate vertically to minimize flashback, even under pressure, and promote improved thermoconduction and moisture vapor transfer through the outermost occlusive film layer. Biatain AG foam dressings also incorporate a novel zirconium phosphate complex that provides the sustained release of high-volume soluble antimicrobial silver for management of local wound infection and odor in acute and chronic wounds. These dressings are available in a plethora of shapes and sizes. They're exceptionally easy to apply, comfortable and conformable to wear. They're offered with or without adhesive borders. The adhesive versions are available in either hydrocolloid or silicone options, which in my opinion makes this one of the most versatile advanced antimicrobial dressing portfolios on the market today. It's been my pleasure discussing this Biatain AG portfolio of products with you today. Thank you so very much for listening. On behalf of myself and the Coloplast representatives that are present at this session today, I welcome any questions you may have about this presentation or about Biatain AG advanced foam dressings.
Thank you so much, Melody. I'm sitting here and I'm grinning a little bit because I too love the rock band example that you posed in your session. And I have a question. I have to jump from the first question to the second question, but we'll go back to the first question in the Q&A. Hey, Melody, I love the rock band example. Just to clarify, will the Biatain AG foam penetrate biofilm without a surfactant?
So yes, actually, when I was researching this presentation and looking at all of the features of the Biatain AG foams, I actually learned that in fact you do not need an added agent. You don't need a surfactant or a chelator or any other additional ingredient to permeate a biofilm using the Biatain AG foams. And again, I tried to touch on it in the presentation itself. Like you probably, I was formerly under the impression that this impenetrable EPS, this polysaccharide goo that is secreted by biofilms, was absolutely untouchable unless you had something to drill through it. But that's not what Coloplast has shown in their research. Which they've shown is if you have a large enough volume of silver that's delivered over a sustained period of time, it will weaken that insular EPS and allow access to the pathogens within it. So again, when I talked about the nano crystalline technology, we get the big dump of silver, but it is dispersed relatively quickly from the dressing, and so this large volume is not sustained. And then when we have other silver products that have sustained release but utilize a much lower part per million or a lower dose of silver, added ingredients or agents are used in order to permeate the biofilm because the volume of silver alone is not sufficient. And those work very well also. But if you're like me, it's almost a privilege to have access to a number of different strategies when we're managing local infection or chronic wounds with biofilms.
Thanks, Melody. Thank you for that explanation.
Sure.
Let's address Amy's question here. This was the first question. I've noticed some care providers in my home care setting using betadine or inidine with silver products. However, I have heard that iodine and silver should not be used together as they have opposite charges and will neutralize each other. Are you able to clarify this?
Sure. First, I'm a little confused about the goal. So when what we know about betadine is that it is basically straight iodine. We know that iodine in its kind of raw form is a potent oxidizer, but it's also cytotoxic to healthy human cells in any concentration greater than 10%. Really, really low concentrations will inhibit kind of key cellular processes for wound healing. So in my practice, we use betadine when we want to create a low bioburden eschar on an unhealable wound. We wouldn't typically use betadine long-term on a healable wound because of that cytotoxic profile that it has. We know that iodosorb and inidine, all of these iodine-based antimicrobials have been engineered to deliver fractional iodine so that it's safer to support moist wound healing while killing bacteria in a wound. So that's a little bit different than straight iodine. I'm a firm believer in swimming in my own lane, so I could pretend to be a clinical microbiologist or some kind of chemistry wizard, but I'm not. So I wouldn't be able to tell you exactly what happens to the charge on charge when you put an iodine-based antimicrobial and a silver together, but also the key thing I think to remember here is it's just not necessary. Only the antimicrobial that's interfacing with the wound will be killing bacteria. So the antimicrobial that touches the wound surface, and I think Heather Orsted et al. Identify this very clearly. It's absolutely pivotal that your antimicrobial and your wound interface directly. So if you're using more than one antimicrobial, only one of them is working. The other one is kind of hanging out on top, maybe interacting with the other antimicrobial that you're using, but more than likely you're getting suboptimal effect and probably unnecessarily increasing the cost of your protocol.
Got it. I hope that answered your question, Amy. I'm going to ask a quick one here that Wanda posed. Would you moisten the foam prior to application to activate the silver, or does the drainage from the wound that is getting absorbed activate the silver?
Yeah, it's the drainage. So in my experience, most locally infected wounds are exudative, and so it, kind of is a natural progression to marry an antimicrobial silver with a foam dressing. And as that exudate is taken up in the Biatain AG foam portfolio anyway, that zirconium phosphate crystal compound that's impregnated in the substrate will release the silver as the cations are taken up. So you do not need to moisten the foam, and I would not recommend moistening the foam because then you're just unnecessarily using up its absorptive capacity.
Thank you for that. Next question is Stephanie. Can you comment on the use in peds? Do you feel comfortable with that question, Melody, or would you like me to defer to Ashley?
Yeah, sure, Ashley. Let's hear someone else's voice.
All right, Miss Ashley.
All right. Yes, silver dressings are used in pediatrics as well as in neonates. It just depends on, obviously, an infected wound is an infected wound, even in small people and in, and I say small people as in kiddos. And of course, in peds, there's no difference in that. So again, it's the wear over time, the ability to have that silver disperse over time, as Melody has alluded to get through those biofilms and to reduce that localized infection. So yes, you can use that, use our products in pediatrics. I hope that answers that question.
Yeah, and I would not recommend using iodine-based antimicrobials in peds. We don't in our practice. So silver is definitely the go-to.
Yes, and I would say that to support the iodine comments from before that Melody said is that I've always referenced iodine as an all-kill, just like Dakin's. It's going to knock the good and the bad. So it has purpose. It has it has a home, but silver for your localized infections and getting that exudate management, peri-wound protection, and the 3D Fit technology is what we would also be looking for.
Perfect. Thanks, ladies. Next question, is a twice weekly dressing change optimal with Biatain as the foam?
Yeah, I mean, you'd have to, as a clinician, make that determination based on the amount of exudate that you're seeing coming from your client. And so you're looking at, wound progression, how saturated is the dressing when you're changing it, what else can you do to reduce exudates? For example, if this is a venous leg ulcer, are they compressed? So my official answer is up to you.
That sounds good. All right, next question. Would the Biatain silicone cause hypergranulation if left for long duration of time?
Nope, not if it's being used appropriately. So you get the sustained delivery of high doses of soluble antimicrobial silver for up to 7 days from each dressing. I would not hesitate to use the dressing, change the dressing 1 time per week in a wound that was maybe a little smaller exudating. But if you're having hypertrophic tissue formation, I would suggest that you could try increasing the frequency of your dressing changes, or if you've been using an antimicrobial for some time, it may be an opportune moment to try culturing that wound to see if in fact it's actually deeper tissue infection where your topical solution is not working. Other potential causes for hypertrophic tissue, of course, friction. Have you taken away mechanical forces? That kind of thing.
Perfect. All right. Next, for case study number 2, for autolytic debridement, was there any other product used in conjunction with the Biatain AG foam?
No. So I'd like to make that fancier.
Yeah.
No. Yeah,
all right.
Foam.
Excellent. Excellent.
Yeah, and I have to add, actually, I have a colleague that I really respect who works in acute care in Southern Alberta, Jody Quinlan, and she was telling me that in her practice environment, increasingly they're using foam dressings for prevention, for pressure ulcer management. And so, I was thinking of her when I was working on this case study as well, because she's seeing increasingly where foams are being used, and if the microclimate isn't managed correctly, or if you've got a client who's maybe incontinent or using multiple layers, then the skin can really become a hot mess. So I really thought that this was a great example to see how the Biatain AG product worked on that gentleman. He's community based, so he's living his life and doing his thing, and I was really quite impressed where Gretchen was able to achieve that level of debridement without mucking up his microclimate and the peri-wound skin.
Excellent. Christine has a couple of questions here. Let me start with the first one. You mentioned combining antimicrobial products is not necessary or similar. What about Kerlix and betadine together? I see this dressing selected often. And maybe I'll augment Melody. She says, clarification, immediately post sharp debridement.
Yeah, so immediately post sharp debridement, if you're using betadine and debriding, again, we use the betadine to build a low bioburden eschar typically. Debridement could occur, for example, if you had a really mucky infected wound and it was imperative to remove all of that non-viable infected tissue that was putting the client's wound or limb at risk. But I question whether or not betadine is the right solution or the right antimicrobial to be using if, in fact, the goal is closure and contraction and wound healing. Kerlix is a good utility dressing in my world. It contains a PHMB, polyhexamethylene biguanide, but it's bound to the fibers of the gauze. So from the literature that I've read, it's not engineered to release PHMB into the wound. It will only discourage bacteria from growing in the dressing. So it's truly a good bacteriostatic option. In my practice, we use PHMB impregnated gauze, for example, in uninfected wounds with tunneling, like our post-op abdominal wounds with little tunnel or depth, so that we don't have to pack them daily, and we can see them a little more regularly because maybe they've had post-op infection. But this will allow us to prolong our frequency of dressing changes to every other day. So again, I question the practice of using a cytotoxic agent like betadine. If you're debriding with an active goal of wound healing, I would suggest a gentler iodine-based antimicrobial, something that's engineered to deliver fractional iodine at a sustained rate, or for example, a really safe, potent, broad-spectrum silver dressing, especially since you've removed all that necrotic tissue, like a Biatain AG foam, because that will manage your exudate and give you your antimicrobial coverage as well. Hopefully that's helpful.
That's great. That's great. I think we'll go back. We've got to backtrack just for a quick second. Melody and Ashley, on the what age of gestation do you say it's safe for? So if we can backtrack just for a second would be great. Maybe that's it, Ashley.
Yeah, I would say that from a Coloplast perspective, we don't have any known contraindications for age specific. If you look at the, the powers that be, the evidence-based practice from like the Association of Women's Health Obstetric and Neonatal Nurses here, at least in the US, I think they have a presence in Canada as well, that, you have to take it on a case-by-case basis. But, a rule of thumb, if a child is 40 weeks gestation, then you would probably be okay to use any topical dressing unless, if there's a known contraindication. So, I mean, we don't do testing per se to say, yes, this is age appropriate. You do have to take it on a case by case for the younger of the kiddos, age group. But I would say, 40 weeks adjusted, you're okay to probably use a silver without any issues. But I can't not say to not just have that care discussion with the physician on the goals and why the wound is infected, and are we looking at something that could potentially become a systemic infection.
Yeah, I agree with Ashley. I think it's so important to be careful because these are fragile little ones. But if you're looking at a clinic as a clinician at a safety profile, most iodine-based antimicrobial manufacturers put limitations on how much you can use or how long you can use them continuously because of the associated problems with systemic absorption on things like thyroid function, and you don't really see that with a silver antimicrobial. So I'm with Ashley. Negotiate that, look at the size of the wound, work with the team to establish the most appropriate antimicrobial protocol.
Perfect. Thank you, ladies. We've got about 7 minutes left to go here. Let's do at least one more question before closing. This comes from Chantel. Would you use any of these products for a severe diaper rash from incontinence?
Probably not, because a diaper rash is not infectious. So a diaper rash is contact dermatitis. And so I would reduce or eliminate the cause, and then I would probably use barrier products to protect the intact skin. Kim's nodding because she's a skincare and prevention guru and probably knows a lot more about that than I do.
Like Triad.
Yeah. So Triad is not a barrier ointment, but it's a hydrophilic paste that can be used on broken skin. We use it a lot for our incontinent adults, for example, or people with spinal cord injuries. We can put it on the open areas if in fact it's progressed to that stage, and then not have to try to affix a cover dressing. Instead, we can just put it on and cover it, with the client's own incontinence garment. Sometimes we'll put an extra booster liner inside of there just to try to keep everything clean. And then you can, irrigate and reapply as needed with hygiene care. But no, I probably wouldn't use any of these Biatain AG products on a diaper rash unless in fact it was infectious.
Perfect. And I am going to ask you, Miss Melody, one final question. I get this often. We don't use silver foams in our practice. How is using a Biatain AG foam, whether it be non-adhesive silicone or adhesive, better than using a silver wound filler and a plain foam, for an example? I know you covered this, but I get asked this quite often, and I feel that it's really goes along with a change of practice. It's a change of mindset.
Yeah.
So how do you, yeah.
So I think one of the things we get a little caught up in, a little hung up in as clinicians, and I've seen this in not just working with Coloplast, but other manufacturers of advanced wound technologies as well, is clinicians sometimes get caught up in the cost per unit and say, well, that foam costs, 30 cents more than this one. But when you're pairing antimicrobials with foams and other materials, so when we're layering products or we're kind of marrying or creating recipes out of our protocols, we're increasing the cost of the per unit dressing change. And oftentimes these advanced dressing products allow us to leave things alone and prolong the frequency of dressing changes. And again, I mentioned in my presentation, I'm community-based. I work in home care and have for a very long time. So it's always optimal if we can teach the clients and families to do their own wound care and give them a product that they understand is an advanced dressing technology, not like a gauze or a Band-Aid that they can buy at the drugstore. And then they actually can apply it themselves and are comfortable leaving it alone because they understand that this is engineered. And then we reduce the cost of our protocol dramatically, because not only have we taken away the number of things that are required in each dressing change, but we're reducing the need for nursing time. We're promoting client autonomy and independence and self-care. And most importantly, we're leaving the wound alone and letting it do what it needs to do. And then we just provide monitoring. So if you're not using a silver foam in your practice, I would ask, why not? Is it lack of exposure? Is it a budgetary issue? Because if it's a budgetary issue, it's probably not well-founded. I would suggest you should probably reach out to your commercial rep and see what kind of options are available to you in your area and consider it.
Excellent. Excellent.
Thank you.
I think myself, as well as nationally, all of our territory managers probably have that same discussion all day long. So thank you for sharing your creativity, but your knowledge and your expertise with us today. It was excellent. Thank you so very much, Melody. And thank you to everybody as well for joining us today. We've got a couple of minutes left to go. So I'm just going to wrap up by thanking you again. And please don't forget to take a few moments to complete the evaluation that you'll find. This is how manufacturers like us learn about your needs and so forth. As well, please don't forget to visit us at our Coloplast booth anytime over the next 3 conference days. We'd love to chat with you. And maybe I'll just say, Melody, do you have anything in closing that you might like to say, or shall we?
Actually, Kim, I just want to thank you and Cassie Alverson for your ongoing support. You guys are goddesses. And of course, Maureen Rigo and the entire team at Wounds Canada for your graciousness and protracted patience. I am grateful for this opportunity. Thank you so much. And of course, thank you everyone for listening.
Thanks, everybody. Have a wonderful day. Take care.
Bye.
Bye for now.